Thanks very much for the opportunity to present at this meeting. I will be speaking on liver cancer in Sub-Saharan Africa. These are my disclosures. So liver cancer is one of the most prevalent cancers, but also one of the most lethal of the major cancers. This information from the International Agency for Research on Cancer shows that by incidence, liver cancer is the 6th most common cause of cancer, but by mortality, it is the number 2 cause of mortality from cancer in this list, second only to lung cancer. More importantly, if we look at mortality ratio, which is a number of the proportion of individuals who will die within a year of diagnosis, liver cancer has the highest mortality ratio of the major cancers, with 92% of individuals dying within a year of diagnosis. The main risk factor for liver cancer globally is chronic hepatitis B virus infection. And there are approximately 300 million people with chronic HBV worldwide. And what this slide shows is that if we look at the top 20 countries in terms of infections with chronic hepatitis B, we see that 9 of these countries, which I've highlighted in pink, are in Sub-Saharan Africa. So this represents a major burden for the African continent. Consequently, there's a high rate of hepatocellular carcinoma deaths in Africa, in addition to the high rate of hepatitis B, which account for the high rates that we see in Sub-Saharan Africa. We also, of course, have high rates in Egypt of liver cancer due to chronic hepatitis C virus infection. There are unique features of hepatitis B virus in Africa that contribute to liver cancer risk. First, most transmission is horizontal, occurring after birth, but before the age of typically 5 or 10 years of age. Second, the HBV genotype E is most prevalent in West Africa, but genotype A1 is the most prevalent in East Africa. Some countries have, such as Sudan, have genotype D being the most prevalent genotype. Overall, HBV DNA levels in Africa are lower than we see in Asia, but HBV appears to be more oncogenic than would be expected based on the low HBV DNA levels that we see in patients. And HBV-induced HCC also occurs at a very young age. Typically, only a small minority of individuals in Africa are aware of their HBV infection. And the consequence of this is that they are not under treatment or under surveillance for cancer. So most HBV-induced HCCs are diagnosed at terminal stages. Some of the factors associated with horizontal transmission of HBV have been studied in rural Ghana by Professor Martinson and his colleagues. And here are some of them. Close contact with objects that have been contaminated with saliva or small quantities of blood, such as the sharing of gum or candies by children, sharing a towel with a household member, sharing dental cleaning materials, scratching of a carrier's back, that apparently is something that toddlers will do in play, biting fingernails, having an increased number of hepatitis B virus carriers in a household, receiving injections by a traditional healer, or having a skin scarification. So in our African Network for Gastrointestinal and Liver Diseases, we performed a couple of studies that I think are very pertinent to this topic. First, we wanted to establish the age of onset of hepatocellular carcinoma in Africa, because there was a lot of anecdotal evidence or anecdotal reports of this, but not a lot of evidence gathered from the African continent. And so in this study, we had 7 different countries across Sub-Saharan Africa, and we collected information on liver cancer patients that had been recently diagnosed at medical centers in these countries. And so we had a total of 1,520 patients that we had data abstracted on. We looked at the age of onset of hepatitis B virus mixed HBV-HCV infection, HCV infection, and then others of unknown cause, or non-viral cause. You can see here that individuals with HBV-induced liver cancer had a median age of onset of about 42, and those with HCV-induced liver cancer had a median age of onset of about 55. If individuals had co-infection with HBV and HCV, they tended to have a median age of onset more similar to HBV. So HBV appears to drive the age of onset in these individuals. Now, when we look at HBV-associated HCC by country, we see that there is some variation. So we can see that that ranges from Malawi, which had a median age of 45, all the way to Sudan, which had a median age of 58. And it's interesting to note that in most of these countries, genotype E or genotype A1 would have been predominant, except for Sudan, where genotype D is predominant, and it's unclear whether, whether that is a primary factor for the difference in age of onset in Sudan. But if we look at Sub-Saharan Africa broadly, this is what it looks like, where we can see that the peak age of onset is in the 35 to 40 year age brackets. For hepatitis B-induced cancer, for hepatitis C-induced cancer, it's more in the 50 to 60 year age range. Consequently, what we find is that Africa has the youngest age at HCC diagnosis and the largest number of years of potential life lost when we have these deaths from liver cancer at an early age. What are the explanations for the younger age of onset for HPV-induced HCC in Africa? We don't know absolutely for sure. This is an area that needs more research, but it could be in part because we generally have a younger age distribution of the population in African countries. But when we do analyses accounting for this, we find that the age of onset is still lower than would be expected. There may be a contribution of host genetics. We know that there's a strong familial association with HPV-induced HCC that has been shown in Asia, for example. We need to do genome-wide studies to better understand this in Africa. It could be viral genetics, where, as I mentioned before, we have low replication of these viruses and low HPV DNA rates, but the viruses, even though they're replicating at low rates, appear to have high oncogenicity. There are clearly environmental factors that contribute, and in many parts of Africa, there's relatively high aflatoxin exposure from grains and nuts that have not been stored, harvested and stored appropriately. And then in addition, there's evidence for co-infection with HDV at some prevalence in most of the sub-Saharan African countries, and also emerging evidence that co-infection with H. pylori may contribute to the inflammatory syndrome and risk of HCC. So here are some of the factors that we think contribute. There's an element of host genetics, likely an element of viral genetics. Lifestyle appears to be a contributing factor as well. And we know that individuals who use alcohol, who smoke, who are obese or have diabetes, all of those things will increase their risk for liver cancer as well. And then we mentioned environmental factors such as aflatoxin exposure. Family history is really important in HCC risk. This is data from Asia that shows, for example, that individuals who have a positive family history and hepatitis B surface antigen positive have a substantially higher risk of hepatocellular carcinoma than those who have a family who have hepatitis B surface antigen positivity, but no family history. And you can see the rates are relatively low in those who are hepatitis B surface antigen negative. This just to remind ourselves about how aflatoxin contaminates grains and nuts in sub-Saharan Africa. And you can see maize and peanuts here and heavily contaminated with Aspergillus species, which contributes to the production of the aflatoxins. So the next study that our team did was to try to understand the characteristics, management, and outcomes of patients with hepatocellular carcinoma in Africa. And here we had a total of 9 countries, including Egypt, that contributed to this study. And looking at 1,250 patients with liver cancer from Egypt compared to 1,315 from other African countries, the age at diagnosis, again, in Egypt is mostly hepatitis C-induced cancer, was 58, compared to median age of 46 in the other African countries. You can see that in both countries, the predominance was males, 78% in Egypt, 69% in the other African countries. Almost 100% of individuals in Egypt had liver cirrhosis. Not surprising because chronic hepatitis C acts through the development of cirrhosis. On the other hand, 66% in the other African countries from Sub-Saharan Africa, where it's primarily chronic hepatitis B virus infection, and we know that a proportion of those individuals will develop liver cancer from hepatitis B virus integration without cirrhosis. If we look at the stage at which they are diagnosed, we can see in Egypt, because there's an ongoing practice of surveillance for cancer in many of those patients, we find a lot of early stage diagnosis. About 30% of patients were diagnosed with stages A or B, early to intermediate stage. On the other hand, in the other African countries, only 5% of individuals were diagnosed with early stage disease. And on the other hand, we see that if we look at late or terminal stage disease, 7% in Egypt, 72% in the other Sub-Saharan African countries. In terms of primary treatments, therefore, in Egypt, 76% of individuals were able to obtain specific treatment for their HCC. In the other African countries, only 3% of individuals had any treatment. And in terms of curative treatment, 35% in Egypt, but less than 1% in the other African countries. So this does make a difference to outcome. This is a combination of studies from across the globe, Asia, North America, Europe, including the data that from our study in Africa. And you can see here that regions and countries in Asia, Taiwan and Japan have very high survivals because they have very high surveillance of individuals at risk for cancer. On the other hand, this is the data for Egypt. Median survival was about 11 months. For the rest of Sub-Saharan Africa, median survival was only 3 months. So this is what I call the surveillance gap, and it shows that surveillance for cancer, identifying those who are at risk and screening them for cancer on a regular basis, can make a huge difference to outcomes. Finally, I'll describe some data from a study that we carried out in Ghana, looking at the characteristics of patients with ambulatory end-stage liver disease. So this was done in 3 tertiary medical centers in Accra, Cape Coast, and Kumasi in Ghana. And you can see here in terms of the BCLC stage at diagnosis that actually, if you look at BCLC stage 0 and A, we have about 12% of the group that were diagnosed at these relatively early stages. If we add stage B or intermediate stage, and that makes up about 31%. So just having clinics at these major medical centers that are actively seeing and surveying patients with chronic liver disease results in an improvement in diagnosis of early stage disease compared to the entire Sub-Saharan African region. But cost is a major barrier to care for patients with hepatitis and liver cancer in Ghana. So this was the adjusted odds ratio of being able to pay for the alpha-fetoprotein test for screening for liver cancer. And you can see here that individuals who had a monthly income, this is a monthly income of less than about $90, had a much lower likelihood of being able to afford the alpha-fetoprotein test. Similarly, the likelihood of being able to pay for an HPV DNA test was much lower in individuals who had incomes less than $90 a month. Finally, it's important to recognize that Africa has been excluded from global cancer research. And so many of the questions that we have to answer have not been addressed, and it leaves really substantial gaps in our understanding of the core basic pathogenesis and genomics of liver cancer in Africa. So how do we find solutions to this issue of the challenge of hepatocellular carcinoma in Africa? I think the key is to start with improving hepatitis screening. And here we have the model that's been carried out in Egypt recently as a guide, where Egypt incorporated screening into a population health program. All adults and adolescents were screened for hepatitis B, hepatitis C, for hypertension, obesity, and diabetes. They formed a national network of hepatitis and liver cancer treatment sites, did bulk purchasing of testing and treatment, the testing and treatment supplies, negotiated prices, were able to obtain World Bank funding, and over a one-year period, were able to test over 50 million individuals. Thus, key needs to reduce HPV-induced liver disease deaths in Africa include informing and educating populations and policy stakeholders, achieving universal hepatitis B vaccine coverage, preventing mother-to-child transmission of hepatitis B virus, promoting hepatitis B and hepatitis C virus screening in high-risk populations, reducing environmental exposure to aflatoxin and other toxins, preventing metabolic syndrome, promoting cessation of alcohol and alcohol use and smoking, developing national programs for HCC surveillance in the at-risk persons, developing and implementing improved early detection strategies, promoting access to HCC treatments, and promoting palliative care for the large numbers of people with end-stage disease. And really, collaboration will be key to addressing HPV and as well as HCV and HCC in Africa. And here are some of the organizations that are actively working in this area. Thanks very much for your attention.